Welcome to Lamakaan and India Civil Watch International's hosting of this event on COVID, the Kerala story, or COVID, how Kerala fought COVID. It's a star-studded panel that we have today, but that's not my responsibility. I'm going to hand it over to Dr. Salima Razvi in a moment, who is going to be the moderator for this event. My name is Vijay Matthew. I'm one of the co-founders of Lamakaan as well as India Civil Watch International. And because I presume I'm the only person who goes back and forth between these two organizations, I am just taking a moment to introduce both organizations. Lamakaan is an open cultural, political education space out of Hyderabad. And we've been in existence for 10 years. As a matter of fact, just exactly about 10 years. And we plan to be shut down, of course, for the lockdown. And, we are trying to think through what this lockdown means, what this what this virus means, and what the future looks like, both in terms of public health, everything from public health all the way out to democracy and politics. So that's where Lamakaan is in Hyderabad, and glad to welcome all of you on behalf of Lamakaan. At the other end of the world, in the United States, is India Civil Watch International. It's a collective institution that's been in existence for over, I would say, 18 years. Started out in 2002 in terms of its long history, coming out of the Gujarat carnage that happened. Been doing an enormous amount of work, as the name suggests, around civil rights, but civil rights defined most broadly as everything from work around anti-communal work all the way out to working on questions of in displacement and economic rights, etc. So that's India Civil Watch International, which is out in the United States. And on behalf of India Civil Watch International, welcome also to this event. We have a star-studded lineup in terms of people who've been incredibly important and incredibly qualified to comment on this, all put together in this panel. And without much delay, I want to hand it over to Dr. Salima Razvi, who is economist who specializes on questions of health interventions. Her entire work for the last 15 years has been on questions of health interventions, the economics of it, and she's part of the Copenhagen Collective, etc. Thank you, and over to Salima.
Thanks, Biju, and welcome everybody to this online panel discussion of the uniqueness of Kerala's fight against the coronavirus. At a national level, where exactly are we today with the COVID-19 situation in India? At last count, there are some 37,500 plus cases, almost 1,200 deaths in India. While the cases haven't really grown exponentially, as has been predicted and postulated upon, there is some debate now on whether we are testing enough and whether we truly understand the extent of spread of infection in the country. Our testing figures, if we go by testing figures, the number of tests per million, which is an indicator of the broadness of testing standards, we fall really short and way behind most of the global standards. I think at last count, we were some 780 tests per million cases, per million people in the country, which is woefully short of what we should be doing. So what we want to discuss today is the Kerala story. Kerala, as we all know, was the first state to report a COVID-19 case end of January. And since then, in February, the cases rose quite quickly and quite rapidly. After that, it's been almost 3 months, more than 3 months now, actually. And we see that there are at least 12 states which have overtaken Kerala in of infected cases, in sheer number of deaths, and we want to understand why that has happened. Kerala has a very poor death rate, a very good death rate, as in only 4 deaths as compared to Maharashtra, which has some 400 and odd. Gujarat and Madhya Pradesh, which started very late. The cases showed up very late, just about a month ago, but they are leading hugely in terms of the number of infected cases and also the number of deaths. So what we want to understand is why, in spite of Kerala with its porous borders, with its huge migrant worker population and also its huge expat population, how has it successfully managed to flatten the curve when it seems that the infection is just growing exponentially across the rest of the country? And to do that, we will be discussing all of this and much more. We have a very distinguished lineup, as Biju mentioned, of speakers with us on this panel, and it gives me great pleasure to introduce them to you. Dr. Iqbal is a renowned academician and also a public health activist. He is also a neurosurgeon. He is the national convener of the Jan Swasthya Abhiyan and past president of the KSSP. And currently, he chairs the Epidemic Response Committee in the state. Dr. Jayakrishnan is a professor of community medicine at Kozhikode Medical College. Dr. Amar Fettel is the state nodal officer of the COVID-19 response team in Kerala, and currently he is monitoring and managing the entire situation in the state. And last but not the least, Dr. Anthony is a national level consultant on public health, nutrition, and child survival. And also he was the former director of the State Health Resource in Chhattisgarh. Thank you all the panel members for joining this panel discussion. And we really hope to learn and understand a lot from your expertise and inputs. Dr. Anthony, I would like to begin with you. How much do you think how much has Kerala, from its successful experiences with dealing with the Nipah and the H1N1 virus not too long back, how has that helped it in handling COVID-19 pandemic state right now?
That's a specific question, or I will take over as the moderator of this session. Good evening to all of you. Thank you, Lamakaan, for this good initiative so that the rest of the world know what Kerala has done. My name is Anthony, and I'm basically a pediatrician and got into UNICEF. From there, got involved in child survival development as a module writer for ministry, and then knew the public health structure from grassroots to the national level. Now I'm one of the monitors of the National Health Mission. Now, as an introduction, I will just say Kerala, the God's own country, was a place of interest from time immemorial to the global travelers, seafarers, traders, and colonial explorers. It was part of the spice route, and Chinese persons, Greeks, and Arabians and Romans knew about Kerala even before the Europeans came to Kerala. French, Dutch, Portuguese, and finally the British came. And Kerala is known for its literacy rate and empowered women and democracy, but communist government coming to rule the Kerala state for the first time through a democratic process and all this. But today Kerala is famous for how it handled COVID-19 epidemic. For this, I got a fellow panelist, and most important, and I will start with, I will reserve my time and answering question to you. I will just go one by one, first to Dr. Iqbal, and then to Dr. Jayakrishnan, and then to Amar Fettel on covering some aspects. Dr. Iqbal, not only as a neurosurgeon and an academician and a vice chancellor of Kerala University, has the privilege of starting from the grassroots and the people's movement for health, and also linking grassroots level community participation by people science movement. So I would request Dr. Iqbal to have the first go, and each of them will speak 10 minutes each, and then later on we'll have a second round of 5 minutes each. I'll ask Dr. Iqbal to talk more about the literacy movement and how the well-aware people got involved, and there was a greater community participation of the strengthened primary healthcare system and a lot of health system reformation in Kerala with people's participatory planning and all, and how, as a background of this COVID epidemic control, how that has helped, especially a lot of ASHAs, Anganwadi worker, Kudumbashree members under JPHN and health supervisors go on the task of not only monitoring, community level monitoring, reporting, and building partnership at grassroots level, and the strengthened primary health care system in Kerala, how it has helped in a more efficient COVID control. Salima, your answer will come in due course. So wait for a while. I would request Dr. Iqbal to speak for 10 minutes, whatever I had asked now. And please go ahead, Dr. Iqbal. Clearer.
Actually, Anthony, who is also from Kerala, though he worked most of the time outside Kerala, has a grip of what is happening in Kerala. And in the email discussion that was happening just before this conference, actually he has listed out all the strengths of Kerala health system. And he was talking about that now. He has listed out a large number of positive aspects of Kerala health. In fact, the Kerala health, Anthony was referring to the past experience, etc. It will be extremely difficult to go back and then discuss all what made the so-called Kerala model possible. Personally, I don't like this term Kerala model. In fact, Amartya Sen used to say that it's better to say Kerala experience, because there is a lot of historical facts that made possible the so-called Kerala model. Well, now, if you look at the COVID situation, you can see that in a way Kerala had a learning experience during the Nipah epidemic, apart from the Kerala health system, but because such type of pandemics needs a particular type of activities to be there, whatever be the strength of your system. So Nipah was an eye-opener, and even though this was confined to Calicut, the northern district, that too part of in a small village in Calicut, and then the patients were treated in the medical college. That was an learning experience for Kerala, because we started discussing about what is called index case, contact case, contact tracing, the quarantine, etc. So some of these public health concept have actually been percolated into the Kerala psyche because of the Nipah epidemic. This was in 2018. There was one case of Nipah reported in 2019. And then we had the flood in 2018 again. This also had a tremendous impact on Kerala. Totally unexpected. The earlier flood in Kerala was in 1922 only. And then again, there was a public health intervention to control the infectious disease that are usually seen along with floods. You know that in most of the countries, the number of people who die of infectious diseases that follow a flood is more than those who die due to the flood itself. But we could control that. So all these were a learning experience for us to confront a major infectious disease breakout later. Though we never expected that, this was a learning experience. Now simultaneously, you know that the Kerala public health system was facing a lot of problems in the late 1980s. In fact, I have written a book on Kerala model of health from success to crisis at that time. The crisis was that the morbidity in Kerala was increasing, both the morbidity due to infectious diseases and also due to non-communicable diseases. NCD incidence increases was expected because the longevity was increasing, and therefore then the NCDs are likely to increase. But the increase was more than what we really expected, because the lifestyle was changing, the food habits were changing, people were not doing proper exercise, overweight, so on and so forth. So the morbidity was increasing. Both we had a double burden of morbidity, and then but the public health system was stagnant at that space to confront this increasing morbidity. So what happened was, in that space, the private health sector moved in a big way. Large number of private hospitals. I won't say it is a corporate hospitals of that level you see in other metropolitan cities in India are there in Kerala. But nevertheless, 60 to 70% of the healthcare is now being done by the private sector because the public sector was stagnant at that time. But the big game changer came in Kerala in 1996 when we started what is called the People's Campaign for Decentralized Planning. In fact, I was also part of that campaign. I was the state planning board member at that time. And Dr. Thomas Isaac, who is the current finance minister, actually kick-started the People's Campaign for Decentralized Planning. You know that 73 and 74th Amendment Bill actually handed over a lot of administrative decentralization. To that, Kerala added two other components. One is that we also decentralized financing. The budget, 25% of the budget is allotted to the local bodies. And thirdly, and most important, planning was also decentralized. See, the money, the fund that goes to the local bodies, 40% of that fund can be used for service sector like health and education, and they can decide where this money can be spent. When I joined the planning board, I was the professor of neurosurgery in a medical college. But though I belonged to a super specialty in the medical college, I found that at that time more than 70-80% of the health budget was going to the medical colleges. This was reversed. Due to decentralized planning, the funding came to the lower level of hospitals. And moreover, you know that WHO has written again and again in several documents that if you want to ensure community participation, you will have to decentralize healthcare. That has happened in Kerala. So therefore, as Anthony has very well written earlier in his posting, that large number of this community participation came in a big way from down below. The ICDS, Anganwadis, the Kudumbashri movement that has come up, the healthcare workers, and also the local self-government representative got involved in improving the functioning of the primary healthcare up to district hospital. From primary healthcare up to district hospitals, we are decentralized. I don't think anywhere in the world so much decentralization healthcare, not only in functionaries and funding has taken place. So this completely changed the landscape as far as the public health system is concerned. That is the game changer. The major game changer is decentralization of healthcare. And in 2006, when the government came, the infrastructural facilities improved. We have the Medical Service Corporation. We established the Kerala University of Health Sciences, and then the infrastructure facilities from down below up to the medical colleges improved. And in 2016, this government started what was called the Ardra mission. Ardra, you mean compassion. So the Ardra mission starts from the primary healthcare centers, which are being converted into family health centers, and the working hours have increased from 2 o'clock to 6 o'clock. More doctors are appointed, more nurses are appointed. All essential drugs are stocked there, and specialty clinics like Ashwas looking at the respiratory problems, and Shwas looking at the respiratory problems, and then Ashwas, which is for looking at depression, and then all the taluk hospitals were provided with dialysis units. Even up to the district hospital, we have now cath lab, and all the medical college hospitals have become. In fact, most of the medical colleges in Kerala are far ahead of other private hospitals in terms of infrastructure and human resources. I can tell you from my own experience as a patient, that will be more striking. In 2007, I had a severe heart attack just in front of the Alappuzha Medical College. I was going to talk to the students for the Kerala University Union meeting. I had a severe heart attack. I was taken to the Medical College Hospital, and there was no angioplasty at that time there. Okay, they thrombolized me and pushed me to a private hospital about 100 kilometers to the south, and emergency angioplasty was done, and I was saved. And after that, bypass surgery was done in a private hospital. But now all medical college hospitals has got angioplasty and bypass surgery. In fact, heart transplantation was done in Kottayam Medical College 3 or 4 times. And I am also an asthmatic. While I was a vice chancellor in 2001, I had a very severe asthma, and then I was taken to a private hospital and I was nebulized. That was the first time I saw a nebulization. Now, even at the primary healthcare level, we have got nebulization facilities. Now we have a drug industry, Kerala state drug industry, pharmaceutical industry. They are improved from, they are making about 250 crores worth of essential drugs. We are going to make chloroquine there. We are going to make penicillins there. You know that Hindustan antibiotics is not functioning now. You see, therefore, that when the COVID came, it was the most appropriate time for Kerala to confront that. We had an experience with Nipah. Our public health system was robust, and then there was a community participation at an unprecedented level, and we learned a lot of lessons from the Nipah epidemic and the flood. So that it was, historically, we were fortunate. I would say Kerala was fortunate compared to many other states. I won't find fault with other states, and I do not want to compare Kerala with other states, because other states did not have this historical experience. So let us be humble enough to say that we had, due to various historical reasons, this experience, starting from decentralization to Ardhra mission, a robust public health system, a community participation. And you know that in Kerala, our social capital is so strong. Social capital in the sense that when we confront with an emergency situation like this, whether it is a flood or Nipah or COVID, all the people from with different and differing political moorings come together. So one thing you see, Amar Jasani and all were talking about taking over the public health system. Do you know that there are 22 private self-financing medical colleges in Kerala? All of them came forward and said that you can take over the private medical colleges and you use it for whatever purposes. This you cannot see in anywhere else. In fact, the Kerala government has taken over 2 private medical colleges with their concurrence, the Kannur Medical College and Wayanad Medical College, private medical college, and made them into COVID hospitals. So therefore, you see that cutting across political lines, communal lines, the private-public divide, Kerala has got a social capital of getting united to confront any eventuality. So that is the reason, basic reason why we could manage the COVID so far. And therefore, because of this external experience, I am very diffident to compare Kerala with other states. Other states may not have this type of historical experience.
Okay, thank you, Dr. Iqbal.
I will stop here. Andy.
Thank you, Dr. Iqbal, for that beautiful narration of. Hello, Dr. Iqbal.
Yeah.
Your voice went off, but it's okay. It's a beautiful narration
Can you hear me?
Now we can hear.
Did I take too much time?
Can you stop now and you can come back? So
no, I am stopping. I do not want to say further. Jay Krishnan is
okay. Now I just you have beautifully laid the foundation of Kerala primary healthcare system, its strength and what is the reason for its strength, and the new features, including the private sector coming in one voice to support this.
Dr. Jayakrishnan, could you continue, please, with your experiences of the COVID-19 management in the state?
COVID-19, yes.
Yes.
COVID-19 was known to the other world outside China in the last week of January 2020. And in the last week, the same day when it was known to the world, Kerala state government have formulated a COVID guideline. Kerala State Health and Family Welfare Department in January 26 itself formulated a guideline and started entry screening in its international airports. And since in Keralites and also the first case in India and in Kerala and India was reported in Kerala on January 3rd. January 13th, the first case. And following this, subsequently, February 2 and February 3, 3 cases were reported from Kerala. But one of the things is that they are included in the entry screening. Those students, they are medical students at Wuhan. They are returning from Wuhan and they are kept in home isolation, home quarantine. And immediately they are under surveillance, these 3 students. And immediately when they develop symptoms, They voluntarily report to the local health system, and they are admitted in isolation in the respective district hospitals. And after these 3 cases, they discharge, and since they follow the home quarantine very well, there is no household level contact. Secondary cases reported, and during the whole February, we are free of COVID. So only 3 cases reported. 3 are isolated cases. No family transmission. No other transmissions. And we have completed almost 28 days. No cases reported from Kerala. And again, in March 9, the first case, 6 cases reported. The cases were from those who were returned from European Union, so the European countries. Then the cases were reported, and till date we are having 492 cases, positive cases, COVID cases, 492 cases, 498 cases below 500, and out of this, 80% cases are under our quarantine. They are travelers. They are reported from those who are traveling from affected countries, most of from our Middle East countries, and only 17 to 18% are from the family contact. Most of them are from travelers returning to Kerala and tourists, and few cases from family contacts. Only 1 or 2 cases are we cannot trace the contacts. So even now, January, February, March, April, May, Kerala, there is no outbreaks or evidence of community transmission. This is confined to local transmission only. That is one of the plus points of Kerala. This achieved mainly due to, one is the political will, and second, as Iqbal Doctor have said, decentralized planning, as well as intersectoral coordination and cooperation of the people. That is strength of Kerala. And you have mentioned about the test. We have done 27150 test, and our positivity rate is only 1.8. Positivity is only 1.8. Without community transmission, there is no meaning of testing, and we are testing all the contact cases. And this is the current figure of Kerala. And one of the other points favoring to us is, I have told as Iqbal sir have pointed out, our health system in the primary care, secondary, as well as very strong, and there is also networking, good networking with all the chains of health system. And one of the positive point is, most of the cases I have mentioned is travelers. So beginning of March, we have started immigration screening in the airport. I have mentioned it. And immigration checkpost, other states, we have heard that Kerala have followed all the guidelines instructed by the central government very correctly. All the details were collected in the entry point, and the declarations were collected, and they were undergone. Every travelers landed in airports where we had to undergo. One, they had to undergo give the declaration. Second, they have to undergo thermal screening. And if any travelers reported with the temperature or any screening, we have shifted to hospitals. And during that time, in the January last week itself, we have started 2 designated COVID hospitals in each districts. We have 14 districts, and out of this, we are having 10 medical colleges, as Iqbal sir have pointed. We have the other private medical college have joined with us, and so every district we have got 2 designated COVID hospitals, as well as 2 nodal officers in every district, and this number were advertised in papers, in channels, so very people are aware of that, and they are sent for home isolation if there is no symptom, every travelers. And every day from the airport itself, if I am working in medical college, Kozhikode Medical College, our students, final year students and house surgeons are deployed in Calicut and Kannur airports. 24 hours they are screening the travelers, and their details are collected, and by online the details are transmitted to the district centers as well as community medicine. From the district centers they are transmitted to the local self-government and local PSC system. So when they reach the home, they will be monitored by the local health and ASHA workers and the PSC staffs. So they are monitored, and whenever they have developed symptoms, they will be brought to the hospital, the designated hospital with the government ambulance, and testings were done. That was the procedures. And by that time, most of the cases, we perceive that we have the first wave of in Kerala, first wave of the COVID have already getting subsided. For the last 7 days, in the north, we are in our college, there was no cases reported in last 7 days. And also since I am working in medical college, we have got a good connection with the district health system, district health services, and the medical college. We are working together in COVID surveillance, as well as travelers monitoring and surveillance, and also households quarantine. We are all working together, and that is the success of our story.
Thank you, Dr. Jayakrishnan. That is part of the surveillance you have said. I would ask one immediate question to fill up the surveillance thing. One of the successes of one of the success points in Kerala surveillance is you are already experienced from Nipah days onwards to have an efficient surveillance system, a real-time web-enabled reporting from the districts and primary health centers, and a state-level analysis and feedback, and monitoring of these contacts and primary contacts and secondary contact. Even from Nipah day epidemic time in Calicut, Kozhikode area, the districts, which is one of the red zone, now orange zone district, had that. So that is, do you agree that that was a bit of a strength, on that already strengthened surveillance system and monitoring and feedback and sharing of that details with the media? What do you say? So that was one thing on the surveillance I would like to add. And also you had one point, because of the audio interruption, I couldn't mention when Dr. Iqbal said about the community involvement. One social capital Kerala had to bank upon is 45,000 registered volunteers, educated youngsters, social workers, all 45,000 human army ready to do anything. And they were manning the kiosks in the airports, bus stations, railway stations, and facilitating this reporting, as well as taking the home quarantine people to designated places or quarantine centers. So that was a great help. I would like to add that on the community participation and the social capital. Now, I would request Dr. Amar Fettel, being the state nodal officer, to comment upon what is the preparations that the secondary level healthcare system has done, district hospitals and medical college, in handling the severe acute respiratory distress cases, in triaging these cases and going testing, and also the preparedness of the health infrastructure as well as the equipments and all. Could you comment on that?
Good evening, Dr. Anthony, Lamakaan members, Dr. Jayakrishnan, and of course our Guru, the respected Dr. Iqbal. Happy to be here. And first of all, I'd like to make a correction in the very gracious introduction that I heard. I'm the state nodal officer, but I'm in no way the person responsible for controlling and monitoring and doing the whole thing. I'm just one small link of a huge and very strong chain of people who are involved in this. I just happen to be one of the links. Now, Dr. Anthony, in response to the question that you have posed, we have had a very long tradition of now fighting this sort of global epidemics. This sort of close encounters of a third kind started off in 2009 when H1N1 erupted with a bang. Very short interval after it started in Mexico, we had the first case landing up in Kerala. So in rapid succession, the first case came to Cochin, the second death happened in Trivandrum. So these were that was the first experience I think the country had in handling this sort of a global pandemic. Otherwise, this was just one word in the preventive medicine, community medicine textbooks that we learned. Our generation hadn't seen a pandemic. So then from that time, we started banking on one of our strongest strengths. It's a very giant national surveillance system called the IDSP, which stands for the Integrated Disease Surveillance Program. So it depends on suspect reporting by anybody, public or health workers, or field staff, which is then taken to a higher level of probable cases identified by trained doctors. And then the 100% confirmation system through the laboratory network. So this suspect, probable and confirmed setup is one of the mainstays. And another mainstay of the IDSP system is very oddly put, it is the rumors. We depend on rumors at grassroots level. So any rumor regarding health at grassroots level is picked up and then either verified or forwarded upwards by the primary health centers or the family health center team, of which the field staff, the people who are called the junior public health nurses, the health inspectors, the junior health inspectors, the lady health supervisors, a big chain of field staff. So these are the people who are the ones who are having the closest contact with the common man and the common families at grassroots level. Whatever they pick up is given due weight, and they have established very good rapport with all these the general public, so that people have the freedom to inform on anything regarding health. And these are all taken up and either dealt with there or forwarded upwards for necessary interventions and corrections and management. So that is one thing that was the strengths of that level. Right after that, I think specifically to before going to specifically what Dr. Anthony was asking about the triaging and management at secondary care level, it has to be mentioned that we started off a sort of control room because starting from H1N1, which I said, then we went through a phase of threat of MERS-CoV. Then we had the 3 episodes at least of H5N1 sweeping the state. Several districts were involved, and we managed to handle it in birds, but without having one single human case. Then we also then had a threat of Crimean Congo hemorrhagic fever, where similar to the present situation, I think 27 nurses traveled back to Kerala from a shutdown hospital in Gujarat because one of the doctors and a nurse had died there of rapidly following a patient death. So this was handled very quietly without none of the fanfare that we have today. The people were all spotted on the way. They were isolated. They were tested, and only after clearance they were then released. We also handled the Ebola threat, where people had come in from the affected Democratic Republic of Congo. I think there were 18 or 20 travelers who came who were probable cases, but that also. So these were all fine-tuning experience. So, and then came Nipah, where very intensive ground level action had to be done at the Kozhikode districts, and also there was a scare in Ernakulam district last year. So these were the disease threats which we handled, and that built up our system. And apart from the diseases, we had 2 devastating episodes of floods and landslides in successive years due to the high rainfall. And this one was the component where the public volunteers, the system which Dr. Anthony was saying, where the common man or the ordinary young people started collaborating with health and disaster management authorities in bringing about rescue services and making that a sort of what we call in Malayalam we say Janakiyam, which is maybe a public involvement kind of disaster management. So there was a massive chipping in of people into that system. So that was the background which we started off with. When now corona infection came in, we immediately started off a control room at the headquarters level with up to 18 different teams looking after the vital areas of management of the scale. So we had anticipated and predicted that this would be a scale much bigger than we had ever seen, and that has now turned true. So we had different teams looking at things like a dedicated team for surveillance alone, and that too airport surveillance, border surveillance, seaport surveillance, all those things. We built up a facility for isolating people spotted in surveillance. So that is where the secondary care level of district level hospitals played their real role. And the COVID care center, COVID hospitals, which Dr. Jayakrishnan was mentioning in medical colleges and in district hospitals, that was rapidly put into action. Then we also had testing facilities were augmented. We started off with zero testing in Kerala, the only test set facility in India being in Pune at the National Institute of Virology. And then we had shifted our testing facility to, we got our unit at Alappuzha running. And then after a very short interval span, we were able to get now at least 16 laboratories of national standard are testing this for coronavirus in the state. Kits and other materials has been a big headache because there was a global shortage for all these things. So there was a real difficulty in getting things. So we had to procure things which were really not being produced. So that was one big headache. So then I have to mention our procurement and distribution system and mechanism, which is called the Kerala Medical Services Corporation, which Dr. Iqbal was mentioning. A very transparent, very dynamic, real-time kind of management of stock assessment, stock procurement, replenishment, and exploring for other procurement. So that was the Kerala Medical Services Corporation role. We anticipated rightly that a massive army of people would need training. So we had trained the people who would man the district hospital isolation units, the IC units, the respiratory care units, the field staff, the contact tracing people, the home surveillance monitoring people. So total about 8 to 9 lakh of specific people were trained by an intensively working training division, which released, I think, hundreds of videos which are now online on YouTube and other locations for use by anybody. We now have stopped sending information down the line. We post everything on our website so that anybody can access it without our having to email things down and email instructions down. So that makes everything very accessible. We also have one very, very vibrant system called a helpline system, which is called Disha in Kerala, with a number which is 0471 255 2056. It went into action and now has handled almost 1 lakh calls of people who need assistance, people who have doubts to clarify, people who need to know what to do next, people who are in distress either physically or psychologically, and people who just want to have some general knowledge. So all these calls have been handled by this helpline number called Disha, which is manned by, I believe, 60, 70 people now are manning the lines 24 hours a day, 7 days a week, and round the clock all the time. So this has been another strength. Now the district hospitals, the previous strengths where we had these units looking after H1N1 patients, the use of things like PPE kits, the training for PPE kit use, all these things were done very, very, very vibrantly, and they were all trained so perfectly that they were able to swing into action without any delay. So these the 28 units, 14 into 2 units that were ready to isolate and care for people with COVID infection of higher symptomatology were ready. A very good chain of what you call control, with starting from the, as I said, the chain of management starting with the health inspectors and grassroots level at one end, but going to all of us here, the medical officers at the hospitals in the districts, and then coming to the Directorate of Health Service and the state NHM, National Health Mission headquarters, and then going right up to the government through the secretaries, the directors, the secretaries, the mission director, and ultimately to our Honorable Minister of Health and Family Welfare. That the motivation, and then that was tremendous in the initial days of Wuhan and Italy and Iran and all that. When the scale of things went up, what has happened is that now it has become a massive governmental effort where all the departments, line departments other than health also have chipped in. And so now the Honorable Chief Minister himself is at the helm of affairs. And the whole system is being steered with a lot of sense of direction, motivation, and very, very good far sight that of the things to come and what we need to do. So that chain has helped us. The dedication of people and the fearless way in which the COVID hospitals are dealing with the dangerous infection has to be seen to be believed. The team, which includes even people, I would leave the doctors there, but I would specifically mention people like nursing assistants, cleaning staff. They are not technically trained, they are not professionals, but the way in which they have joined with the system and are doing everything with precision and courage and dedication and ownership is the thing that has made the management of patients at the what you call the district hospitals and the medical colleges very, very good. And yet another area is the psychological support, because this is all very distressing. It's very easy to tell a person to sit in quarantine at home in a room, but if you sit there for 2 days, we know it's very distressing. And there is a lot of tide of mental distress all over the state, which has been very, very effectively handled by the state mental health team with up to 2,000 volunteers who are there in counseling, local visits, monitoring everything. So altogether, the linkage of all these people has enabled us to handle COVID on a social scale, on a medical scale, which is linked together and has made it very, very person friendly or public friendly. So that brings in the public support. So this is one of the things that has been very, very encouraging to all of us, and we feel very happy at what is happening and the way in which we are moving.
Thank you, Dr. Amafetal. I found we'll come back for a second round after this, but I want to comment on twice it was mentioned about not testing adequately. Even Salima had raised that issue. WHO put this mantra, test, test, test. And what do you mean by test, test, test? So everybody thought there is a infection spreading, silent infection in the community. We are not unearthing it. There were TV channel discussions, and one of the lab chain owners in Delhi, he was making anything. There is a bomb there in the community, and that's not export because we are not testing. Now, testing for the listeners in this forum, there are two types. One is for diagnosis of this COVID virus, that we are testing the RNA of the core sender of the virus, and that is diagnostic test. The other test is the rapid diagnostic, the RNA, the diagnostic test, which is assessing the RNA genome, is costly, 4,500 per kit, and it is cumbersome. It takes 6 hours to get minimum to get the results, and that we have to diagnose in the acute phase. It is a must. Okay, we understand that. But the rapid diagnostic kit, which everybody was hammering on, and that is to give an indication for surveillance. It is for surveillance purposes, whether already an infection has taken place. The problem with the rapid diagnostic kit is that it can be tested only after 21 days of minimum 14 days of infection passing. So it helps you only for surveillance, and it is the spike antibody, spike protein or envelope protein we are testing in that, and it is less costly, only 1,500 or 2,000. But when we imported those kits from abroad, they were found to be not satisfactory. We had to discard, and ICMR has stopped it. Now, when we say WHO was accusing that India is not testing enough, that is a time when we look at this test per million population. There is a big fallacy there. The denominator, like Italy, France, and Spain, and South Korea, which has done, is the total population of the countries. Those countries, the total population is so small. India has got 736 and 1.3 billion population. If you put the number of tests done, which is with the RT-PCR or the RNA genome testing, it is the number will be much less, not according to the WHO's norm of tests per million. We are nowhere near. But if we consider the test done per case, we are far superior than Japan, Singapore, and Italy, and even USA and UK. If you see how many RT-PCR tests are done per case, we are at 25.9 per thousand cases, and then there is 25.9%, and Singapore is only 20.5, and Japan is much less, and Italy is only 7.6, and USA, UK is 5.3, 3.3. So if you change the denominator, if you exclude 364 districts out of 733 districts in India, they are not affected, and there is not a single case. We exclude that population load from that, we are much better. We are doing a better job. And that too, so Kerala proves again, they have wisely used their RT-PCR test for specifically to diagnose the cases, the travelers, cases from the travelers, imported cases, and from there, their primary contact and secondary contacts. Now, to remove this myth about there is a big asymptomatic carriers which we are missing, recently, just last week, Kerala completed 3,000 RT-PCR kits and testing that. Out of 3,103, they found only 3 positive cases with RT-PCR or the RNA genome testing. That means there were 3 persons were without symptoms carrying. Whereas in Bombay, Mumbai, Maharashtra, they are saying there are a lot of cases are without any symptoms, and they're exaggerated. It is by general population, asymptomatic, positively infected viral that's about 5%. Whereas Kerala, we found only 3 out of 3,001, that will come to less than 1%. So Kerala gives an excellent model that don't go too much about testing in the far out in the community. Concentrate on your positive cases. Testing does not reduce mortality, whereas clinical care makes a difference. So that is the conclusion, because that testing is given too much of importance nationally, but which is not worth the time spent compared to.
I want to add something here.
Okay.
Kerala did not have any model for testing. We simply followed ICMR guidelines. That should be very clear. Kerala did not have any separate model for testing at all. We followed the ICMR testing protocols. We have a state medical board who discusses and publish this. And you know that if you look at the ICMR protocol, they made 2 changes. One, they added SARI at one stage, the severe acute respiratory infection, and now they add ILI also. But then there was a demand from the community that the tests are not done adequately in Kerala, and also we were about to do a zero surveillance in Kerala using antibody test. But unfortunately, the antibody kits that were supplied by ICMR from China were not validated properly. They were of substandard, and therefore, as part of a community surveillance, we from a vulnerable groups, we are now doing 300 test PCR test as part of a community surveillance, 300 tests on alternate days. So I want to make it very clear that Kerala did not have a separate model for testing. We followed the ICMR guidelines.
Okay, so that the Kerala, the way the government orders have given, maybe ICMR, it is quite a sensible model. It is in the sense, it is not a fixed random sampling of the entire population for with the rapid diagnostic kit, because rapid diagnostic kit only will show you a past infection. It is not an immediate diagnosis. That should be your RT-PCR, which is there. And that,
Anthony,
yes,
we were not very much satisfied with the ICMR guidelines, the expert group.
Yes, there is.
today we were discussing with in our live streaming in Facebook live streaming. We are discussing with the Director General of the ICMR, wherein I suggested to him that, see, in the case of SARI, ICMR guidelines says that only admitted SARI cases. So I suggest
just
that
this is expansion, because some of the viewers are not medical. That is subacute SARI, that is subacute
respiratory infections.
and influenza like illnesses. So that is what ICMR wants to do. Okay, go ahead, Doctor.
So I suggested to him today that their rules are very stringent in that only admitted hospitalized SARI cases, severe acute. I said that, of course, if it is severe, it will be admitted, but a less severe acute respiratory infection, if there is a clustering by IDPS statistics, that also should be included. In the case of ILI also, I suggested to him that as per their guidelines, it should be in a hotspot, in the migrant group, etc., etc. I said that also should be a bit diluted. And again, in ILI also, if there is a clustering, not only in the community, but even in the family clustering, that should be also included for testing. So this we suggested. But as such, we are following the ICMR guidelines.
Yeah, but so that some sort of a stratified purposive sampling is needed, because we don't have the luxury of that many kids to just go far out into the community. It is not required. The success is we are going by a contact tracing method and high risk group or around that in the hot zone. So that it makes sense. As of now, there is nothing, we don't have to feel shy about WHO's critical remarks. So WHO might make some blunders even now. Initially, they said no need for wearing masks. There is no airborne infection. Now we are saying that mask is necessary. So let us take this with what has learned out of experience, and that is what I want to make a comment on the testing strategies. And
whenever there is community transmission, we need more tests.
Yes,
exactly. Kerala, it is confined to travelers and their family contacts. Now this strategy is very 100% correct epidemiologically. When there is community transmission, we are not able to track the contact. In such cases, we need.
Technically, that is, sir. Dr. Jayakrishnan, thank you for that. This is a technical comment. We need RDKs and all when you don't know what's happening in the community, when the community spread has taken place. But we were in the initial phases of disease epidemic, where there are imported cases, and from their contacts the disease is spreading. Community transmission has taken place in slums of Mumbai and Delhi from the first primary cases. And then don't know. Then you are in a very high density population of slums. The community transmission is expected. There we have to go with such strategies, not for the entire country. Okay, now
Kerala, sir. Sorry for the interruption. Another indicator, as per the records, we are having 4 lakhs interstate migrant workers.
Yeah.
Among these migrants, we are all give them corona. They are admitted or they are given shelter. They are staying in corona care centers or some other houses for the last 30 days. And out of these 4 lakhs, no single case of COVID have reported. That means
I want to make this point to the audience very clear. See, the lockdown strategy, just like community testing is a need when there is community spread has taken place and we don't know where the patients are or the infected are. So same way, physical distancing and lockdown strategy works when there is massive community transmission has taken place, as in Italy, as in Spain, which has gone beyond. Whereas if you are efficient to start from the beginning of the epidemic, you know where the positive cases have come from and you contain it, community transmission will be much less. Okay. Now, Salima, how do we go about? We take some questions now. I was looking at the time. We have taken our time of the panelists. Salima, you can see how many questions have come. We can take some of them and the panelists can take.
Yes, Dr. Anthony, thank you. The first question that has come up is about the migrant worker crisis itself. I mean, what we were just discussing. So, I mean, some of it was mentioned by the panelists, but how did Kerala manage the entire situation with the large migrant worker population that it has? We've seen the crisis that has erupted across the country with the lockdowns in place. What was the state's response and policy in providing food and essentials to the migrant workers in the state? And also, how did it handle the entire situation of the internal migrants, that is, those from the other states? I mean, I heard about the Corona care centers and about 4 lakh migrant workers being, put up there. But what was the state's response?
I would request Dr. Jaykrishnan already mentioned something about the Northern Kerala. Dr. Amar Fetal, you want to add something on the migrant population?
Yeah, here what we have done for the migrants is that one is that they were all listed. We have been what we call keeping tabs. So that might not be the right word, but we have a very what we call a list of comprehensive list of migrants. So that because that was done for providing a lot of services, looking after their welfare. So these ways the government departments know where the migrants are, approximately how many are there, from which states where they belong to. So with that in mind, and knowing the fact that lockdowns and other things would create hazards, the hurdles in their going back. So what we did was proactively we planned for providing support, keeping them well housed, well taken care of, with food of their choice, multilingual, multi-language information campaigns, and regular visits by our public health teams and volunteers to ensure that they are well looked after. So that way we helped or were able to create a feeling among other migrants here that you are in friendly hands, you are in just like a mother's hands, you will be well taken care of, your needs will be met. So that way they were taken care of. So that was the way that we were able to look after the migrants.
Okay, I would like to come in here, Salima, that first I want to remove one myth that just because they are poor, they are migrants, they are not harboring primarily this virus. They may be harboring TB, they may be harboring malaria parasite, but not COVID, not coronavirus. Coronavirus is an imported virus. It came from travelers, Indians who have come from abroad, and visitors. It is a virus that had enjoyed the flight and landed here. It is not a virus that emanated from the gutters or the poor people. So there is some sort of a prejudice. It's one of the prejudices in this epidemic. The migrant laborers are a threat. They were not a threat till these Bombay slums and all. We made them a threat because we locked them up. They were locked down. They were forced to remain in enclosed, limited area without food, without any other amenities. And you plant a virus of a secondary infection from that has come from the hospital, or maybe, and then there is you plant a virus among them. Now they may be at. You did not handle them properly. It is, if you could bring people, Indians from Saudi Arabia, Iran, and Italy by special flights, and Dubai, these migrant laborers, which was not epidemiologically a threat at all, it was a disease of the upper middle class and upper class, not of the poor migrant laborer. Now you might have made them one of the things, because physical distancing cannot be practiced in a limited space where they live in. And that happens applicable to the Dharavi slums and Mumbai slums and Delhi slums and Ahmedabad slums, Surat slums, everywhere. You need, if at all there is a positive case proved, you need a reverse quarantine. Bring them and put it in an isolation ward rather than locking up that with all police bandobast and not allowing anybody. So the virus multiplies there. They cannot.
Correct.
I want to make that point.
Absolutely correct, Dr. Anthony. And building on that, how important do you think the role of communications has been in handling this crisis in Kerala? We all know that there were daily briefings by the the chief minister, the health secretary, and the chief secretary also. I'm sure that played a huge role in allaying the public's fears, removing misconceptions about this virus, and preventing, rumors spreading. How important do you think the role of communications has been for Kerala?
Dr. Amar already briefed it. I would ask Dr. Iqbal to come in, and the role of technical advisory board and the politicians and bureaucrats listening to the technical people, which is very prominent in Kerala. Dr. Iqbal, you would like to comment?
There are three technical groups who are working on this. One is the State Medical Board. Second is the COVID cell, where Petil and others are there. There are various experts. The Director of Health Services, Director of Medical Education, they are a rapid response team. Every day they meet, discuss. And also the expert group, which has been formed also. In fact, it is not a parallel group. We always interact with each other on various issues. And the Chief Minister every day at 4 p.m. earlier, because of the Ramzan, he has changed his time, but every day he convenes a meeting of the senior officials at 4 p.m. where the chairperson of the expert group is also invited. So what we do is that in fact, this is a time when we discuss at night at 9 o'clock, we discuss, and if necessary, we ask for, in fact, Dr. Arvind, who is part of the State Medical Board, is a member, Dr. Chandini is also a member. So there is a horizontal integration also is taking place. So we may ask the chief, in fact, the health minister comes one day to the expert group for discussion. Now you know that the expatriates, Keralites are likely to come back. So we invite Dr. Elangovan, who is also handling NORCA, that agency which is concerned with the expatriates, the Keralites. So we discuss with them. So at 4 o'clock in the senior officials meeting, I am also invited as the chairperson of the expert group. So we make presentation there. The chief minister has asked me only one thing. You talk science to us. We may take a decision according to various other factors are to be taken into consideration when the government takes a decision. But you can very boldly talk science in this group. So that is what I do in that session. And some of the things which we say immediately accepted. And he will announce at 5 o'clock. He briefs 6 o'clock. He briefs the press, and many other things which we say he immediately accepts, discusses, accepts, and announce in the press conference. And the press conference is attended by all people in Kerala. At 6 o'clock, they are glued to their TV. Now it has been shifted to 5 o'clock. Say, for example, Monday we made the presentation and said that we have to go for universal reusable mask. That we suggested. You know that earlier WHO and CDC was against everybody using face mask. Only those who are the health workers should use it, N95 mask and surgical mask, and the others should cover their mouth when they sneeze and cough. But later they also changed. So we told the chief minister after a discussion in the expert group that it is now the time for introducing reusable face mask. So that was announced by him. So like that, the scientific matters are presented before the minister and the higher officials, and they may accept certain of these things. And then today, for example, there was a suggestion how to test the expatriates, the expatriate non-resident Keralites when they are coming back. What test should be done? In fact, the chief minister was advised that if they have symptoms, they should be subjected to RT-PCR test. So we modified it. We said that that is not enough. If there are not symptoms, they should be subjected to antibody test. And we have prepared a protocol. We have prepared a flow chart of testing of the expatriates Malayalis coming back from this. And it may take some more time for them to come back. So these facts are then presented before you. And therefore, you see that the experts The bureaucrats, the ministry, everybody interacts with each other. It is not a vertical system where the chief minister is ruling the roost. In fact, he listens to you and then take appropriate decision and announces it to the people at the end of the day. So there is a horizontal integration and vertical integration. There is a networking going on. It is a democratic setup. I would say it is a democratic setup. I can tell you very frankly, it's a pleasure working with our chief minister and our health minister. They listen to whatever you say, but they may take appropriate political decision. They will have to consider so many other factors. So it is I am sure that Petil will also agree with me. It's a pleasure working with our chief minister and health minister. You can be very frank, you can be very democratic, and therefore that is how the whole system is functioning.
Very right. Yes. Sir, can I just add a word to what Iqbal was saying?
Dr. Amar Fetal want to just add one.
Just a couple of words, because one of the very extraordinary things we have been experiencing is that the Minister of Health and Family Welfare, our Shailaja teacher, comes and sits with us in the control room and discusses with us for hours on end and is there with us. So that is a pretty extraordinary thing. I don't think many states would have the experience of a minister coming and sitting with a group of officers who are doing all this. And we have a very good team at the control room. A lot of youngsters, very junior doctors are there, people like us are there who are the senior end. But having a minister sit there for hours, it's not exaggerating, for several hours there, many days, that is a very, very motivating experience. So what Dr. Iqbal is saying, it's a real pleasure.
I would add to that one comment of a nursing superintendent who said after the COVID duty, after each 7 or 10 days of continuous duty, they need to go for a 14 days quarantine and then reach home and meet their small kids and come back for the next round of cycle, and the trauma that is there in the psychological trauma that happens. And so she said, but when we meet our health minister, we get so motivated. She's such a thing. And even when she goes for a ward round among the patients, she says, is there anything lacking in my sister's doing? And please tell me. And she just gives the pats on the nurses in front of the patients and says, is there anything, please? Is the sisters, are they not looking after you well? Please be frank. And so she addresses them as my sisters and my family members. So that is something good.
Dr. Antony, some more questions now on the clinical treatment of the disease. So a couple of questions which I'm clubbing together. Could you please discuss the use of ventilators in the for treatment of very critical patients? Were ventilators used? Was intubation required? And if it was, how effective a treatment it was? And secondly, the second question, was convalescent plasma therapy or hydroxychloroquine or BCG vaccines ever used in treatment in Kerala?
Okay, I will come to some of the general thing. There is how the virus behaves is still a hello.
It's audible. It is audible.
Audible. We can hear you. Yeah.
Okay. There is one thing I want to comment on: the contribution of many of the Kerala doctors from Kerala working in USA, UK, and Italy, Naples, and many places. They had this international video conferencing and technical expert coming in. And one of the consensus that has come is that we still don't know how the virus behaves. There are so many theories, and none of them has proved to be the thing. So including even hydroxychloroquine, initially we thought there are theories supporting that. There are some studies, but double-blind control, random control studies, though it is a smaller sample, even that is doubtful. The use of ventilators is also after beyond certain point, it's questionable. Initially, the virus is supposed to have caused a pneumonia. Now we are saying it is not really a pneumonia. It is more of immune reaction in the near the air sacs. So, and then there is the damage. Human RBCs, which carries oxygen molecule, is damaged. So it is, even if you give the oxygen to the maximum level possible, you still have an oxygen starving in the bloodstream because there are not enough RBC, healthy RBCs can pick up the oxygen molecule because of this virus has invaded it and destroyed it. So there may be that is a reason for fresh blood RBCs might do some damage control. Then there is ventilators. Of course, there was a respiratory distress. So we are trying to increase the oxygen concentration using ventilators and preferably to some extent non-invasive type of ventilation, and then 100% oxygen supply. All these things are there, and antiretroviral therapy also is doubtful. So nothing is a thing. In spite of all this, Kerala is trying, as far as from the interaction I had in the video conference, it's like that. I myself is sitting at Bangalore under the lockdown effect. I got trapped on a national health mission visit to Chindwara district in Madhya Pradesh, and from Nagpur I could reach Bangalore. So I am stuck. I don't have a day-to-day contact. It's so the ventilators. There is thinking. Will ventilators fully work? No, even that is not found working in some cases. Then we use hydroxychloroquine to minimize the immune reaction, minimize the damage of this porphyrin ring, which is essential for oxygen carrying. So that is how an antiviral effect of the hydroxychloroquine. But what we can say is that the tertiary care centers all lined up with adequate ventilators, centralized suction, oxygen, with all the PPE, skates in the infusion pumps and monitors. I don't know anyone else in the panelists would like to add on to this. One word on plasma, pooled convalescent plasma therapy. Trivandrum Center was first applied for it, and ICMR was about to give all the approvals for convalescent plasma therapy, but now I hear it is it is not taken off as far as I understand. But Delhi already they have tried, but it is under trial. It is not a regular treatment protocol. It is under trial. It is being initiated. It is supposed to be hopeful, at least by banking upon a natural process of neutralizing antibody production of a recovered patient. These pooled plasma could be helpful in fighting the virus. That's a hypothesis to be proved, and it seems working in some cases, some small trials in China, and it has been, it was not so successful in Ebola, but it was successful in SARS and MERS. I think convalescent pooled plasma. So that is a reason why it is being tried. But when nothing is fully proved, which was, we have to try one by one, and it is medically, it is a big medical science hasn't solved the final solution.
Sir, about
Also, I would like to put one question to the panel.
Okay, what Jaykrishnan want to add?
Sir,
yes.
The BCG, that BCG will give protection to corona. That is based on ecological study. That is spurious association only. That is not evidence-based also.
Okay.
BCG
that is about BCG again. It is a retrospective analysis of the data of BCG immunization status in the community vis-a-vis a correlation. It is a correlation paper that has come out from New York of those BCG immunization status of the country vis-a-vis the COVID virus, if it is infected, how much of mortality and morbidity it has led to. But a prospective randomized controlled trial is now going on in Australia, in which 4,000 healthcare workers are pulled in, and the results will be available only on 2000 after 1 year, 2021 mid. And so then only we will know whether it has got any value. But it is BCG initiates a non-specific cell-mediated immunity towards many infections. That is an old knowledge. Only they are trying that old knowledge, putting it in statistical terms, and they found a correlation. But that is too premature to say. It is a hypothesis still.
Also, Dr. Anthony and the other panel members, is it true that there are 2 mutations of the virus in the country, and that some parts of the country are affected by the more deadlier mutation as compared to, for example, the southern states, which are lesser, showing lesser number of infected cases and lesser exponential growth? Is that true, or is it just
Anyone else want to comment? Otherwise, I will say that is still, even ICMR hasn't agreed on that. Is still in India, that is not validated. That is the what we are.
All
but
right. And yeah, thank you.
Yes.
And finally, a couple of questions on the lockdown. Given that Kerala has shown great foresight in planning ahead and in surveillance and contact tracing and ensuring that community transmission did not happen, one question wants to know what the state is doing in terms of lifting the lockdown, and what are the right conditions for opening the economy. Would be helpful to hear your thoughts on this. Secondly, again to do with the lockdown, in Telangana, as you know, there's been a 13-hour window to buy essentials. What was the window time given in Kerala? Were people allowed to go out and buy essentials and groceries, or was it delivered to their doorstep? What are the parameters which should be considered while deciding who should be allowed to shop and who should not be allowed, and who should be given delivery at doorstep? The new color coding scheme that has come out has in the red, orange, and green has these parameters put in place that elderly people above 65 will not be allowed to go out in any of those 3 colors regions. So how does one handle that?
Dr. Iqbal, could you answer, or Amar Fatal from Trivandrum?
Generally, we follow national government's directions. Generally, in fact, of course, somehow we are managing. You see, there is a easing out of lockdown in different places. That shops are now allowed to function, but closed spaces with AC, like the malls and theaters, are not open. Schools and colleges are not open. But then the cars are allowed to run single digit one day and double digit second day, and slowly it is easing out slowly. But generally speaking, see, our CM, though he has a difference of view about politically from the national government, he has a working relationship, fairly good working relationship with the national government. I would say that lockdown has greatly helped Kerala. Otherwise, large number of expatriate Malayalis might have come into Kerala. And Kerala's borders are very porous. And you take, for example, Tamil Nadu, it's a hot spot. So I think lockdown has largely helped Kerala.
Yeah, thank you. Thank you for the lovely panel discussion. I have 3 questions. The first one related to what Dr. Iqbal has raised about the second wave of the international or the Indian diaspora living in the Gulf, and they are coming back to Kerala maybe within months. So are these people going to be screened? Massive amount of people live in Gulf. So is Kerala prepared for it? The other one is Kerala is also riding high on a big tiger now because of the economic.
We are doing our homework.
Yeah, that's one. The other quick question is, can the country and also the globe learn something from Kerala? Because can that be replicated? Why and why not?
That question, that part, I'll leave it for the final, my take-home message. But as you said, Dr. Iqbal already explained, we are going to get at least 3.5 lakhs expatriates coming, and then there are people who are coming from other states. All of them, as of now, they have to undergo the 14 days quarantine. Where will you quarantine them? All those issues and how to handle it is yet in process. But Salima, if there are no further questions, I will just wind it up with some take-home message.
There's one last question, Dr. Anthony. One last question. So we know that Kerala has the highest per capita, consumption of alcohol. How did the state deal with that during the lockdown?
Kerala, there is a lot of paradox that highest literacy with still highest women atrocity, but also highest number of mental illness, with so much of literacy, high consumption of medicines. All these things are some paradox. One of the things is Kerala cannot do without consuming some alcohol. So also Europe. So, but I don't know. Anyone else want to add on that? How the government's more of a political decision, but it is affects mental health and family health also. Yeah. Anyone else want to comment on that?
Can I just mention this? The psychiatric help division or psychological support division has also a lot of specialists in what we call de-addiction system. So, so they were also in link with the people, and we had in fact initiated a small thing to even prescribe small quantities, but that went into rough weather. But the thing was that the support systems were able to deal with it to a large extent, I think so. But one can never say, because the addiction to alcohol is something unpredictable. So, but we were involved in handling, we anticipated and we were handling it.
Okay. Salima,
I think you can do the concluding remarks. Yes, please.
Okay.
Yeah. Yes.
So, on the whole, thank you very much, my fellow panelists, and I hope those who attended, this will be very informative about the Kerala, what they have done, and I really say, I echo Dr. Iqbal's word. This is not a Kerala model, but Kerala's learning that has happened. And if you find anything meaningful, you can emulate it elsewhere. This is also, Kerala is also part of India. So our best appreciation for our way of handling this is some other states also follow it, so that the people of India gets the benefit. So some of the take-home message now is, we knew from the beginning this virus is an imported virus, and it is not a disease which is endemic there. So we had a screening of travelers from the beginning, and we focused on a case containment strategy and reducing morbidities and mortality of the affected people. And then from there, active tracing of contacts, and we have containment measures of Kerala is something which is rest of the country can see and take a few cues on from that. Second is, we had an added strength of a large community participation through the local self-governments, the Gram Panchayats and Nagar Panchayats and Block Panchayats and Jilla Panchayats, which has got not only the authority given by through 73rd and 74th Amendment, Parliament Amendment Act, Constitutional Amendment, but also they had the fund. Up to 40% of the planned fund is given to the local bodies, and they used it, and that to a large amount of it is in social sectors. So we had a decentralized planning which built up primary health care from grassroots, from the Gram Panchayats to the PHCs and health sub-centers. So that is a model yet to take place in many states. That Kerala had a tremendous social capital of volunteerism coming and displayed, cutting across all religious, socio-political barriers, and one body they face these challenges, whether it is the last year's flash floods or epidemic, whatever it is, we have faced it boldly, even without much of help, even by central government. Another lesson what we have learned, the decisions with regard to an epidemic was taken, the advisors of the technical advisory body fed adequately into political leaders and bureaucrats how to make policy decisions and implementation of it. Kerala, the fourth point, the Kerala is that when not only this epidemic, we found it as an opportunity. We made use of this great opportunity to strengthen our secondary level care and tertiary level care by way of improving our intensive care units and technologically advanced treatment modalities and taking inputs from global centers through our doctors and technocrats. Fifth point, I want to say, we never had any prejudices against particular religious sects or particular social strata. They are responsible for this disease, and we treated our guest workers. That's the terminology we use, politically correct terminology we use. We call it as guest workers rather than migrant laborers. So we took care of them very well, including the train loads that are moving from Kerala yesterday onwards, from Kerala, first train to Orissa, and subsequently the train to Jharkhand today from Calicut, and many trains will follow. We took care of them. We were waiting for approval from Ministry of Railways to take it up, and finally those hurdles are all removed. And so that is something which other states should emulate. And I make a fervent plea for these unfortunate people who are stranded and still in temporary camps in Delhi and other places, Mumbai and all. They need to go back home and take care of their food, nutrition needs, water needs, sanitation needs, till this unfortunate period is passed over. I hope we will further learn more lessons, and we'll show some lessons for the rest of the world also. Thank you very much. Over to you, Salima.
Thank you, Dr. Anthony, and thank you for the entire panel for your expertise and inputs and extremely interesting discussion. Summing up, I think what has been the biggest takeaway is that what's really helped Kerala has been its extremely robust public health system, which has been around for a long time, not just something which has come up, a few years ago. And also its culture of grassroots democracy, which you mentioned, which has, with its, power devolution to the village council, which has largely helped in measures such as community outreach, contact tracing, and of course, mass quarantine, along with the surveillance and the community participation. The volunteers that you spoke of, that kind of participation at every level is unheard of in any other state. I can't think of any other state with a similar level of community participation. We really hope that the country learns, like you said, from not the Kerala model, because it's not probably correct to say that, but the Kerala's way of functioning. And we hope that we manage to control the epidemic, the pandemic in other parts of the country too, as you have very successfully done. Flatten the growth curve, shown that, even though you were the first hotspot, so to speak, so successfully managed to contain it extremely well. Thank you so much. Thank you, Dr. Jayakrishnan, Dr. Anthony, Dr. Iqbal, and Dr. Amar Fetal. Thank you for your time and spending so much time with us and your valuable knowledge. I'm sure the entire audience is also very appreciative of it. Thank you so much.
Thank you. Good night.
Good night. Thank you.
Right.